Traumatic cardiac and great vessel injuries. Introduction. Injuries to thoracic great vessels can be divided into various according to the structures, which include aorta, pulmonary arteries, superior inferior vena cava, innominate vein, azygous vein. Aorta and its branches include brachiocephalic artery, subclavian artery, and carotid artery. Injuries may be acute or chronic. Acute could lead to death or exsanguination, and chronic could lead to fistula formation and post-traumatic pseudoaneurysm. So when somebody is analyzing, one has to look for anatomical anomalies as different branches of the subclavian arteries, like vertebral artery, they can arise directly from the aortic arch. Etiology and pathophysiology. The penetrating trauma is more than 90% of thoracic great vessel injuries, and it could be GSW, SW, or sharpening associated, iatrogenic with central line placement, CT placement, intra-aortic balloon pump placement, emergency room thoracotomy, Swan's-Ganz balloon overinflation, and self-expanding metal stents, esophageal or tracheal stent, and low-riding tracheostomy tubes. Blunt trauma, particularly susceptible to innominate artery, pulmonary veins, vena cava, and thoracic aorta, cause 10 to 15% of the death following MVC. Proximal descending 54 to 65, ascending and transverse arch 10 to 14%, mid and distal descending 12%, and multiple sides 13 to 18%. Blunt trauma, the mechanism could be shear forces, which are relative immobility of a portion of the vessel adjacent to a fixed portion, atrial attachment, pulmonary veins, vena cava, descending thoracic aorta, ligamentum arteriosum, and diaphragm. Compression between the two bony structures, like innominate artery, may be pins between sternum and vertebra, and profound intraluminal hypertension. Blunt trauma, aortic, most commonly full thickness traumatic dissection, is very rare, equivalent to ruptured aortic aneurysm that is contained by surrounding tissue, intact parietal pleura, maintain permissive hypovolemia, and controlled tachycardia. Exsanguinating hemorrhage die within 0 to 2 hours after injury, mortality nearly 100%. Extensive multisystem injury with hemorrhage often being from the sites other than that of thoracic aorta die within 2 to 4 hours of injury, mortality is 96%. CNS injury usually hemodynamically stable but die anyway, and mortality is 5 to 30%. Pre-hospital management, judicious IV intravenous fluid administration, excessive fluid resuscitation with the goal of increasing BP to normal or supranormal level may actually increase the mortality, ARDS, and other post-op complications. Increased blood pressure may actually blow out a soft perivascular clot. Endotracheal stent intubation and rapid transport. History is very important. Length of a knife, firearm type, number of rounds fired, and patient's distance to the firearm, amount of hemorrhage at the scene, intermittent paralysis or hemodynamic instability, head-on or side impact of motor vehicle collision, and commonly cause aortic injuries. Aortic injuries also reported with equestrian accidents, blast injuries, orthopedestrian accidents, crush injuries, and fall from height more than 30 feet. Physical examination, follow the ATLS protocols, clinical finding, pericardial tamponade, look for hypotension, upper extremity hypertension, unequal BP or pulses in extremities, external evidence of major chest trauma, expanding hematoma at the thoracic outlet, intrascapular murmur, palpable fracture of the sternum, palpable fracture of the thoracic spine, left flail chest. 50% of the patient with aortic and great vessel injuries present without any physical injury. Fast ultrasound pericardial blood and plus minus tamponade. AP chest X-ray place the radiopaque marker over the penetrating wound. Findings: large hemothorax, foreign bodies out of focus, suggest intracardiac location. Trajectory with confusing course may indicate migrating intravascular bullet. Missing missile with a GSW to chest suggests digital embolization and in the arterial tree, distal embolization in the arterial tree. AP chest X-ray: 7% of the patient with blunt trauma, normal appearing mediastinum on the admission chest X-ray, loss of aortic knob contour, funny looking mediastinum, and mediastinal widening more than 8 centimeters. The tracheal deviation, depression of the left mainstem bronchus, apical pleural hematoma, massive left hemothorax, fractures, sternal fracture, scapular fracture, multiple left-sided rib fracture, and the first fracture. Initial management: thoracotomy in extremes, fourth intercostal space, left anterolateral thoracotomy, open pericardium, cross clamping of aorta, temporarized bleeding, open cardiac massage, transport to or once the vital signs are re-established. Tube thoracostomy, hemo or PTX or pneumothorax, attached tube to repository for autotransfusion if significant output is noted. Urgent thoracostomy more than 1500 cc initial output and more than 200 to 250 cc per hour. Avoid CVC in upper extremities if concerned about the great vessel injury. Blood transfusion allow for moderate hypotension. Increased BP may blow out a soft protective perivascular clot. Limit fluid administration until operative control of bleeding is obtained. Avoid hypertension. Decrease incidence of ARDS and worsening of pulmonary contusion. Beta blockade decrease dP by dt to minimize shear stresses on the aortic valve and may be used in hemodynamically stable patients who require a delay for definitive treatment. Reduce the risk of the fatal rupture, and there is a retrospective data only and no prospective data has demonstrated the safety or efficacy of such treatment. Spiral CT of the chest, mediastinal hematoma could be shown, or there is intimal flap of dissection, or there may be active extravasation which can be highlighted. Angiography is essential for localizing the injury and planning the appropriate incision for or the placement of the graft if performing endovascular repair. Negative results may convey the false security. Laceration may have temporarily have seal off. Column of the aortic contrast may overlay a small area of extravasation, obtain multiple tangential views. Consider in patients mechanism of injury, PE, chest X-ray, CT, chest. Also be aware that patients can have aortic ruptures even after seemingly unconscious mechanism, low speed motor vehicle collision with airbag deployment, intrascapular back blows to dislodge the esophageal foreign body. Non-operative management: consider in patients unlikely to benefit for immediate repair, severe head injury, risk factors for infection, major burns, sepsis, heavily contaminated wound, severe multisystem trauma. Attempt to achieve physiologic optimization and prove the outcome of repair. Avoid hypertension. Beta blockers has been used successfully in cases of non-threatening aortic lesions and may heal spontaneously. Small intimal flaps, aortic or brachycephalic, small pseudoaneurysm. Long-term natural history is uncertain, therefore close follow-up is recommended. General cardiac injuries, blunt cardiac injuries and penetrating cardiac injuries. Blunt injuries, the cardiac contusion is commonest and usually partial thickness injury is as rupture is fatal. High speed deceleration often associated with rib fracture, sternal or thoracic spine fractures. Clinical features include low BP and bradycardia, raised JVP, arrhythmias, MI type syndrome, and tamponade. ECG changes: ST segment raised or depressed, Q waves in anterior leads, brady or tachyarrhythmia. Penetrating injuries, several presentations, exsanguinating hemorrhage, tamponade group, and asymptomatic cardiac injury. Pericardial, including in penetrating, unstable cardiac tamponade, stable cardiac tamponade, asymptomatic subclinical pericardial injuries, and common cause is precordial stab. Clinical features: stable tamponade, period of hypotension, reversed with 500 to 1 liter of crystalloids with elevated CVP and JVP. Unstable cardiac tamponade, shock or hypotension and tachycardia, dyspnea, raised venous pressure, JVP and CVP, pulses, paradoxes, unreliable distant heart sounds, and impalpable apex. Subclinical pericardial injuries, pericardial rub, pneumopericardium, raised ST, J waves, straight left cardiac border, globular heart, node ECG screening tool, ultrasound, no valve, no fluid present. The patient fits into one of the three groups: accepted indications, relative indications, and contraindications. Accepted indications: penetrating the traumatic arrest with previous witnessed cardiac activity pre-hospital or in hospital, unresponsive hypotension with systolic less than 70, blunt unresponsive hypotension systolic less than 70, rapid exsanguination from chest tube more than 1.5 liter. Relative indications include penetrating thoracic trauma with traumatic arrest without previous witnessed cardiac activity, penetrating non-thoracic traumatic arrest with previously witnessed cardiac activity pre-hospital or in hospital. Relative indications include blunt thoracic injuries, traumatic arrest with previously witnessed cardiac activity pre-hospital or in hospital. Contraindications: blunt injuries, blunt thoracic with no witnessed cardiac activity, multiple blunt trauma, severe head injury. ECG changes: in penetrating, there could be electrical alternance, especially if there is pericardial effusion, J waves more in the pericardial injury. Blunt trauma, MI-like changes, multiple PVCs, sinus tachycardia, atrial fibrillation, and bundle branch blocks. Location of the cardiac injury: the most survivors are of isolated injury type, cardiac highest survival rates, and great vessel is poor, pulmonary hyla even poorer. If the patient is reasonably stable, CVP line insertion, intubation, RSI, peripheral IV, chest X-ray, chest drain, cross-match 4 units of blood, ultrasound, sub-xiphoid window to look directly if no ultrasound. Incision: left anterior lateral fifth intercostal space from nipple to the anterior medial mid-axillary line, rib retractor to open up, enter the fifth interspace and open the pericardial sac longitudinally. Note anterior to phrenic nerve. Once open, scoop out the clots. Usually a clinical improvement is evident. Locate the hole in the heart if present. Place a finger on the hole. Either insert a Foley's catheter with 5 ml of saline or suture close. Proline thread, pledget of Dacron can be used. Avoid coronary vessels within suturing. Check for a thorough check for through and through wounds and tie off internal mammary artery if it has been traversed, and look for any other injuries. If they survive, then take to theatre for closure of thoracotomy. Endovascular stenting began in 1990s. Cape reports and a small series reported of endografting of proximal descending thoracic aorta transactions. Initially, the surgeons were using custom devices with aortic extenders. Currently, devices size ranges from 26 to 40 millimeter. Average diameter among the patients with aortic injury is 19 millimeter. Manufacturers allow 17% oversizing. When oversized, more than 17% of the graft is at risk of compression and infolding. 85% of the injuries are less than 1 cm from the takeoff of the left subclavian artery. A seating distance on either side of the injury of 2 cm is needed. Therefore, left subclavian artery occlusion is at the risk of endovascular repair. Surgical repair. The indications for immediate operative intervention is hemodynamic instability, significant hemorrhage from CTs, radiographic evidence of rapidly expanding mediastinal hematoma. Be aware potential for neurological complications, paraplegia, stroke, and brachial plexus injuries. Document a careful neurological examination. Prophylactic antibiotics, limit fluid administration, autotransfusion, avoid wide swings in BP during induction. Operative approach depends on the overall patient's assessment and specific injury. Adequate exposure is critical in order to obtain the proximal and distal control. Prep from neck to knees. In stable patients, CTA or femoral angiography may help dictate the operative approach. Have appropriate graft material available. Prosthetic graft is preferred for vessel diameter greater than 5 mm. Failure mode of infected graft is equal to pseudoaneurysm. Infected saphenous vein may cause graft dissolution with acute rupture and uncontrolled hemorrhage. Uncertain injuries unstable. Left anterolateral thoracotomy plus minus transverse sternotomy plus minus right anterolateral thoracotomy clamshell. Ascending aorta median sternotomy, transverse aortic arch median sternotomy plus minus neck extension. Descending thoracic aorta left posterior lateral thoracotomy. Innominate artery median sternotomy with right cervical extension. Right subclavian artery and vein median sternotomy with right cervical extension. Left common carotid artery median sternotomy with left cervical extension. Left subclavian artery and vein left anterolateral thoracotomy. Third or fourth interspace with a separate L supraclavicular incision plus minus connecting the median sternotomy trapdoor. Pulmonary artery main and intrapericardial median sternotomy, right or left hilar ipsilateral posterolateral thoracotomy. Pulmonary vein ipsilateral posterolateral thoracotomy, innominate vein injury, median sternotomy, intrathoracic vena cava median sternotomy. Distribution of the arterial injuries with penetrating mediastinal trauma, innominate 38%, aortic arch 28%, LCCA 18%, left subclavian artery 8%, ascending aorta is 7%. Ascending aorta rarely survive transportation. Total cardiopulmonary bypass usually required for posterior injuries. Dacron graft survival approaches 50% of the patients with stable vital signs on arrival to trauma center. Always consider the possibility of peripheral bullet embolus. Transverse aortic arch median sternotomy with extension into the neck provide a complete exposure to arch and brachycephalic branches. Exposure can be further enhanced by the division of innominate vein. Use of balloon tamponade by uh, may limit the hemorrhage. Lateral arteriography, simple repair, cardiopulmonary bypass, posterior laceration, concomitant pulmonary artery injuries. Survival also approaches 50%. Innominate artery, median sternotomy plus minus cervical extension, blunt proximal injuries actually represent the aortic injuries requiring proximal control at the transverse aortic arch. Penetrating injuries anywhere, divide innominate vein if necessary. Innominate artery, the partial tears running lateral arteriography for proline sutures, complex tear, the bypass exclusion technique, ascending aorta to distal innominate artery Dacron graft. Avoid the area of injuries until the area of bypass insertion are exposed. No need for hypothermia, systemic heparinization, or shunts. Place a pericardial flap between the graft and the vein if vein is left intact. Pre-hospital mortality is 85% for blunt injury if patients arrive alive. Most injuries are located at the aortic isthmus, at the ligamentum arteriosum, just distal to the takeoff of left subclavian artery. Treatment option: clamp direct reconstruction with or without interposition graft, medical control of proximal hypertension, passive bypass shunt, pump assisted bypass, traditional cardiopulmonary bypass required heparinization, aortofemoral bypass using centrifugal pump, heparin is not necessary, atriofemoral bypass, and a non-operative and or purposeful delay in operation, medical control of hypertension, close radiological monitoring, and Other option is endovascular stenting. The surgical repair, we need to do the posterolateral thoracotomy from fourth intercostal space, proximal control obtained by the aortic arch between the left carotid and left subclavian artery, avoid injury to the left recurrent laryngeal nerve. CP should be available and apply vascular clamps, proximal aorta, distal aorta, left subclavian artery, close communication between the surgeon and anesthetist, clamping, give vasodilators to prevent the cardiac strain during the clamping, and unclamping large volume of fluid administration, avoid clamp release hypotension. Surgical repair, interhematoma, control intercostal artery bleeding, avoid indiscriminate ligation of intercostal vessels, proximal and distal ends of aorta are transected, esophagus repair end-to-end interposition graft. Mortality rates 0 to 55%, average is 13%, primarily associated with multisystem trauma due to head injury, infection, respiratory insufficiency, and renal insufficiency. Paraplegia is the most feared complication. Passive shunts and cardiopulmonary bypass consider debate. Clamp and repair virtually the same incidence of paraplegia as traditional repairs with bypasses and shunts. Determinants and multifactorial. The preoperative hypotension can cause paraplegia, injury, ligation of intercostal arteries. Duration of the clamp occlusion. The length of cross clamp time does not directly correlate with the occurrence of paraplegia. Less than 30 minutes has been argued to provide a safe margin against paraplegia. Recommended shunting techniques if more than 30 minutes, however, the shunt provides no protection for the region of the spinal cord that is supplied by the clamped arteries. Also, the recognize that the patients requiring more than 30 minutes of the clamp time have more extensive injury. Therefore, it is likely that the increased paraplegia in this subset of the patient is actually secondary to more extensive disruption of intercostal arteries and other flow to anterior spinal artery caused by the original injury. Subclavian artery could be intrathoracic, thoracic outlets, cervical zone 1, and upper extremity. It could be a right subclavian artery with median sternotomy with plus minus cervical extension, left subclavian artery, proximal control, anterolateral thoracotomy, second, third intercostal space. Distal control supraclavicular incision can be combined with infraclavicular incision to avoid the removal of the clavicle, may be connected with sternotomy, the trapdoor, and deltopectoral groove incision, and may also consider removal of clavicle. Avoid injuries to the phrenic nerve. High associated rate of brachial plexus injuries. Repair done by lateral arteriography, interposition graft, rarely end-to-end anastomosis. Left carotid artery mirrors the approach of the innominate artery injury and median sternotomy plus minus left cervical extension, transection of the origin, bypass graft repair, and preferred over end-to-end anastomosis. Pulmonary artery, intrapericardial, we have to do the median sternotomy, minimal dissection of the main or proximal, and dissect between the subclavian and ascending aorta. Anterior injuries, primary repair, posterior injuries, cardiopulmonary bypass. Mortality rates approach 70%. Distal injuries present with a massive hemothorax, repair via the ipsilateral or posterolateral thoracotomy. Rapid pneumonectomy may be necessary in the life-threatening situation. Tamponade with balloon exsanguinating hemorrhage. Internal mammary artery injury may produce the massive hemothorax or pericardial tamponade, usually discovered by accident when thoracotomy is performed for suspected great vessels or the cardiac injury. May be ligated for control. Intercostal arteries may cause massive hemothorax. Ligation is necessary for control. May require a large suture taken circumferentially around the rib proximally and distally. Thoracic vena cava, isolated injuries to the suprahepatic inferior vena cava or superior vena cava is rare. Mortality is more than 60%. Intrathoracic IVC, hemopericardium plus minus tamponade. Exposure is extremely difficult. Usually requires total cardiopulmonary bypass with inferior cannula into the groin. Enhanced repair by opening the right atrium and placing a balloon in the cava to prevent the air embolism and massive blood return to the heart. Repair is done from the inside of the cava to the right atrium. SVC, the lateral venography, may require the intracaval shunt, may use PTFE or Dacron interposition graft, may also use saphenous vein panel graft, usually too time consuming, risk for blowout. Pulmonary veins difficult to manage by an anterior incision, usually require an ipsilateral thoracotomy. Consider temporary occlusion of the hilum. If ligation is necessary, resect the lobe as well. Subclavian veins, the operative approach is similar to the arterial repairs, repair the lateral venography and ligation. Azygous vein not usually considered a thoracic great vessels, however, the large size, high flow cause injuries and could be life-threatening. Best managed by suture ligation of both sides of the injury. Systemic air embolism is caused by penetrating wound that injures a pulmonary vein or bronchiole from a fistula, allow air bubble to enter into the left heart and embolize to the systemic cannulation, coronary arteries, MIN, cardiac arrest, cerebral arteries, seizures, CVA, and death. Treatment: thoracotomy, clamping of the pulmonary hilum to prevent further embolization, aspiration of the air from the left ventricle, Trendelenburg position with the right side down. Foreign body embolism, the thoracic great vessels may serve as both an entry site or the final resting place for intravascular bullet emboli. May produce infection, ischemia, or injury to the organs distant from the site of the trauma. 25% lodge in the pulmonary arteries. Should be removed to prevent the pulmonary thrombosis, sepsis, or other complications and may be done via fluoroscopic guidance or open technique. Post-op management, the careful hemodynamic monitoring, avoid hypertension and hypotension, IVF pressors and vasodilators. Pulmonary complications, atelectasis, give PEEP, respiratory insufficiency, pneumonia, ARDS, and close monitoring of a fluid administration. Hemorrhage, technical problem, urgent reoperation, coagulopathy, monitor correct with administration of FFP, cryo, ECT. Graft infection, avoid bacteremia, strict sterile placement of CVC, post-operative antibiotic as needed, prophylactic antibiotic prior to the invasive procedure, dental etc. Long-term complication, stenosis, thrombosis, AV fistula, graft infection, pseudoaneurysm formation. Conclusion: many patients with great vessel injuries die in the field. Many die from exsanguination, while others have the assortment of associated injuries. Those patients that arrive in the trauma center should be treated rapidly, follow the ATLS protocol, rapid assessment of injuries, quick transport of CT, angio, or be aware of anatomical alterations. Have a multitude of incisions in your armamentarium. Be aware when, where to use the damage control operations. Thank you.